42 is addressing concepts related to the child with a psychosocial disorder. Please take a moment and stop this presentation in order to review the learning objectives. said, the treatment can be extremely challenging for a child with ASD. The correct treatment will depend on many factors, and those will include the age of the child, the severity of the disorder, and whether the child may have or not other medical problems. Um, as a general rule, there is no cure for ASD. However, most of the children are often able to overcome many of the problems that it causes. A main treatment goal for this type of condition will be to bring the child to a point where they have the highest level of functioning, however, within the limitations of the disorder. Whenever we are treating a child with autism, we need to provide structure. Their schedule needs to be directed and very organized. The treatment will focus on behavioral and educational interventions that will target the core symptoms, and an early intervention is essential. In some cases, we may use medication that may address both medical or psychiatric um, uh, components of behavior, such as hyperactivity or inattention, aggression, anxiety, or depression. In addition, many families will rely on complementary or alternative therapies. In terms of nursing care, um, the caring for a child with ASD is definitely bringing a lot of stress in the family, and the entire family will feel it. And a child that has ASD will require a lot of attention, continuous and undivided. A lot of caregivers will feel guilty, despite the fact that um, many current theories accept that there is no organic cause for the disorder. So um, the fact that the parent is not to blame, it doesn't take away the guilt. In addition to that, there are most of the time, there will be other children in the family, and they will, in addition, suffer from a lack of attention due to the caregiver's energy focusing and totally being directed to solve the problems and dealing with the concerns for the child with the ASD. Um, the nurse's role will be to provide the family and the caregivers will as many and valuable sources of information about the child's habits and communication skills. While related to the child, they will need to gain cooperation learning um, from the caregiver the techniques that they have and they use to communicate with a child. In a hospital setting, this type of child will need a private or semi-private room with minimum visual and auditory stimulation. Any type of familiar toys or other objects that the child is connected to them can be brought to the child in a hospital setting to reduce the anxiety. The attention deficit disorder, or the ADHD, or the newer terminology is ADD, is considered a syndrome. And inside this syndrome, we can find several degrees of inattention, impulsive behavior, or hyperactivity. In terms of incidence, it's been found that up to 10% of all American school-age children will have a certain form of ADHD, with boys being more affected than girls. In general, the etiology for the condition is unclear. There will be a certain developmental lag. There may be some biochemical disorders or food theories, sensitivities that, and all those are theories that are evaluated currently. In any way, this disorder will have an effect on every single part of the child's life. They will manifest with impulsiveness. They will be easily distracted. They will have fidgeting and squirming. It will be very difficult for them to sit still. They may have problems following through on instructions. And as opposed to a patient with autism disorder, they do understand the instruction. They have a hard time following them. They will have inattentiveness when they are spoken to. They will lose things. They will leave an activity in the middle uncompleted and they will jump to another. They will have big difficulty in taking turns in waiting patiently for their turn. They have excessive talking and they may engage in dangerous activities. Um, in other words, those children may often demonstrate clumsiness or poor coordination, and that can be seen as soon as age 3 or 4. However, this is the range of symptoms that can be seen in a child with ADHD, and no child will really show up all those signs, and most of them will show only a few of them. What do they have in common is the fact that they have poor success in the classroom, and that because they are unable to pay attention, and not because their intellectual ability is impaired. They may also have problems with discipline. They may have learning disorders such as dyslexia or perceptual deficits, and they will need special type of guidance because of that. They may feel inferior to other children in the class because of their inability to keep up with their peers. In terms of diagnosis, a diagnosis can be made only after age 3, and usually those diagnoses are not made before the child is reaching school age, and they are in a setup that requires them to pay attention and to focus. They will usually have trouble settling into the new routine of being in a classroom setting. Um, the diagnosis can be difficult and sometimes may be controversial. And in some cases, there are experts that are concerned that teachers will incorrectly nowadays label a child as hyperactive when there can be just bad class management on the side of the teacher. Um, there is for sure a need for a multidisciplinary approach for an effective diagnosis, and that will involve both pediatric and education specialists, along with psychologists, the classroom teacher, the caregivers, and others as needed. In terms of diagnosis, we establish that based on history that will include, in addition, the school and social functioning, psychological testing, physical and neurologic examination of the child. In terms of treatment, the treatment is, just like the previous condition, multidisciplinary. And the learning situation should be structured in a way that the child will have minimal distraction and is totally supportive for the child. Uh, there is a need for home support, and in addition, that will require structure and guidance from the caregivers. In some conditions, some medication can be added. The stimulation medications such as methylphenidate, Ritalin or Concerta, and dextroamphetamines as dexedrine have been shown to have good rates of success because the stimulants on a hyperactive child seem to have a paradoxical um, uh, calming type of effect and allow by stimulating the area of the brain that helps in concentration, enable the child to have a better control over their life. In any case, the caregivers need and the medical professionals involved in the treatment need to have a calm and patient attitude toward a child with ADHD. This type of child will need to have one simple instruction given at a time. By, in addition, limiting distraction and using consistency will help them to um, improve. In addition to all those, it is a good idea to offer prize for any type of accomplishment. You are caring for a child with ADHD. What is important to do in caring for the child? A. Teach family that structure is counterproductive. B. Maintain a calm, patient attitude. C. Give sedatives. D. Work with school to maintain activity level. The answer is B. Maintain a calm and patient attitude. Maintaining a calm, patient attitude toward the child with ADHD, the child needs to be given one simple instruction only at a time, And limiting distraction, using consistency, and offering prize for accomplishments help the child to improve their performances. Enuresis, or the bedwetting, represent the involuntary urination that will be observed in a child that is at an age when control of urination is commonly acquired. The condition may have a physiologic or psychological cause and may indicate sometimes a need for further exploration and treatment. The encopresis is a chronic involuntary fecal swelling, um, again observed in a child that is beyond the age when the control is expected, usually 3 years of age. In both cases, we may expect the child to show speech and learning disabilities. Whenever there is no organic cause present, the encopresis may indicate a serious emotional problem and may require counseling for both the child and the caregiver. Some organic causes for encopresis may be the megacolon or worms. In some cases, um, there is a belief that over control or under control by the caregiver may produce the encopresis. The treatment will differ based on individual cases, while the most important goal is common, is to recognize the problem, referral for treatment and counseling to reestablish a good um, reflex. Bullying represents a form of aggressive behavior. This can be deliberate and repeated, usually toward a person um, that is perceived by the bullying person as physically weaker or shy or less able to defend him or herself from the abuser. In this situation, one person is the victim of the bullying, um, and the individual who acts as the offender is known as the bully. The bully, on his own or her own, may have been a victim of abuse in the past or might have witnessed violence as a normal behavior in his or her life. In most of the cases, the bully will act to gain power or control over a person, often someone who is in some way different or perceived as different or does not seem to fit in with the others. The behavior of the bully is vicious and in most of the cases will lead to more violent or even criminal behavior as the child will get older. The bully will lack social skills, will break rules, will be impulsive and easily frustrated, and most of the time will lack any type of empathy, any type of caring attitude towards others. The child that is a bully may have psychosocial disorders and will require professional help in order to deal with those issues and overcome the behavior. School phobia. Nationwide, absenteeism is a huge problem, and children may be absent from school for a variety of reasons, and one of them may be school phobia. Um, the children may develop school phobia for a variety of reasons. They may be, um, and most of the time, they will be a good student, and the incidence is higher in girls than in boys. Both teachers and school nurses should be trained in identifying and detecting school phobia by paying close attention to those absence patterns and observing the child behavior when present in school. In terms of clinical manifestation, the school phobic children may have a strong attachment to one parent, usually it's the mother, and they exhibit fear of separation from that parent. And a lot of times, anxiety plays a role in it, and they may be afraid of losing him or her while away from school. The school phobia may be an unconscious reaction for most of the kids to, um, in order to, and signifies an overwhelming problem at school. Um, the parent may unwittingly reinforce school phobia by allowing the child to stay home when the child doesn't want to go to school. In some cases, even physical symptoms may be present as vomiting or diarrhea, abdominal or other type of pain, or even the child may have a very low grade fever. And those are not fake, those are totally genuine. The body responds like that to the high level of anxiety that is almost a panic attack. Those symptoms, however, will disappear immediately once the child is given permission to stay home. The treatment is complex and needs to include, beside the medical examination, in order to rule any organic cause for the symptoms, will include collaboration between the school and the family in order to identify what produces the high level of anxiety. Um, it is important to emphasize to the child especially that they are not to blame. They really do want to go to school, but for whatever reason, there is a panic attack associated with the mere idea of them being in school. So the school nurse, the teachers, along with the social worker, the school psychologist or psychiatrist if needed, together with a caregiver, may need to analyze and find a good solution that will overcome the child fear for going to school. Depression is defined as an emotional disorder in which the child may have persistent sadness or unhappiness. And this state of mind will interfere with doing any type of activities that he or she will normally enjoy. Depression in children is way more difficult to recognize because um, the signs that may indicate depression in an adult are very hard to differentiate, to distinguish from any type of emotions that are seen in a normal development. Young children may exhibit as a normal pattern of growing and developing symptoms, anger, irritability, changes in appetites and sleep patterns, any type of physical complaints and difficulty concentrated. However, the depression is observed more frequently in adolescents than in younger children. The symptoms may be seen in adolescent, may be, however, similar to those in child. In addition, there will be behavioral changes such as missing curfews or defiance, shoplifting, dropping grades, spending more time alone, talking about death and suicide, um, use of drugs or alcohol. All those can be signs of depression. Um, Suicide is a major concern in all those children that suffer from depression, and monitoring closely for signs that may indicate that the child is at risk for suicide is a priority. As I was saying before, um, with depression being a serious disorder, suicide is a main concern because it's a symptom, it's part of the big picture of a depressed child. The treatment for depression needs to be quickly and efficiently applied and may include, beside therapists and discussions with the child, like psychotherapy, they may include medication as antidepressants. As I said, the suicide is one of the leading cause of death in children 10 to 19 years of age, and is just is very close behind the death rate for homicide. Um, However, some of the deaths are reported as accidents, particularly one-car accidents. A lot of them are in fact the suicide act of an adolescent. So males will have a higher rate of committing suicide, about 4 times higher, greater than girls. Um, so the boys use more violent means of committing suicide than girls do, and they are because of that they are more successful. We need to keep an eye on those children that have attempted suicide once because they have a higher risk of attempting it again, and this time they may be more effective. All those attempted suicide will have some kind of warning. Very small number of cases will come without a warning. And usually the warning is that long history of emotional problems, a difficulty forming relationships, a feelings of rejections, or low self-esteem. In addition to that, if the child lost one or both parents through death or divorce, a family history that includes suicide of one or more members, and a lower academic success in school or athletic performance, all those are risk factors for an increased rate of suicide. In the child situation may be further complicated sometimes by unwanted or unplanned pregnancies, by alcohol or drug addiction, or by physical or sexual abuse that may even lead to depression and feeling of hopelessness. In terms of clinical manifestation, again, are all those elements that I was describing before. The initial interview with the child need to include questions that will try and identify if they are feeling, if they have feelings of alienation, depression, or hopelessness. In terms of treatment, it is important that counseling and treatment resources to be applied as quick as possible to have this type of children. We will need to help the child understand that although suicide is an option in problem solving, this is such a final option with no exit. It's very final. Um, we need to be aware that there are many resources out there as hotlines and counselors that specialize in working with people who are contemplated or have attempted previous suicide. And we need to provide those sources to both the child and the family. Substance abuse represents the misuse of an addictive substance that changes the user's mental state. The commonly known abuse substances include tobacco, alcohol, and controlled or illicit drugs. Children can be influenced by their peers in some instances. Sometimes they may be influenced by adults in their own family to use drugs or alcohol, and that because that may be perceived as an easy fix, and instead of facing their own problems, kind of escape and forget the pain of life as they see it. Sometimes this can be seen as adding excitement to social events or um, because they want to bow to peer pressure. We know through history that people have used alcohol and other mood-altering drugs as a means of relieving the tensions and pressures in their life. Unfortunately, frequent use or abuse of those substances can lead to addiction or dependence. Dependence is that compulsive need to use a substance for its satisfying or pleasurable effects. Dependence can be um, psychological, physical, or both. The psychological dependence represents the fact that the substance is desired for its effects or sensation that it produces. That can be alertness or euphoria or relaxation or a sense of well-being and a false sense of being in control over your life. The physical dependence, on the other hand, will result from the changes that the drug will produce at the level of body tissue function. And in order for the body to continue to function, it will require the drug to have the same concentration all the time. The magnitude of physical dependence determines sometimes the severity of withdrawal symptoms. There can be in the withdrawal symptom, we see both physical and psychological symptoms. And those may include vomiting and chills, tremors, and hallucination. The symptoms may vary and they depend on the amount, the type, the frequency, and the duration of the drug use. Um, Whenever we are using an addictive substance, um, as a result of adaptation of our body, we develop what is called a tolerance. And that's the ability of the body to endure and adapt to continued or increased use of a substance. As a result of that, the dynamic of this process is that the drug user will need larger and larger doses of the same drug in order to produce the desired effect. There are 4 stages of use that have been identified, and they can describe the progress of substance abuse. We have the stage 1 that is described as experimentation, learning the mood swing. Um, and during this stage, um, the individual will be curious to try it, or maybe peer pressure, or they may attempt to assume the adult role. In terms of behavior, they are feeling good. Um, they can return to normal. They are in the what is called in the learning mode. The family reaction in most of the time is inexistent because they are often unaware, and when they are, they may exhibit what is called denial. They don't believe that something like this happens. The second stage is seeking the mood swing, and at this stage there is an increased frequency of the use of that drug. um, the tolerance starts to establish itself, and the individual is doing that um, because of a social function or to impress others, or because they are simply modeling some adult behavior. In terms of the behavior that they exhibit, um, they are using to get high. They are using to feel relieved, especially um, from the anxiety, and also because they are in denial of their own problems. The family at this stage reaction may be to try and eliminate the issue, or they may try blaming other for the problem that the child has. This third stage will be the preoccupation with the mood swing. Um, and, and during this stage, they will they will use the drug more frequent. They will have a steady supply, and they will have few or almost no friends. Um, they are doing that because they are used um, to they are used to have their own fix, and they need the constant level of drug in their blood. In terms of behavior, they become more reckless. They use before or during the school. They use despite consequences. They may use it when they are hiding themselves. They have this type of solitary use. They start having trouble at school at this stage. They may overdose and have bad trips. Um, and their physical condition as well as mental condition starts to deteriorate. The family in this stage usually will either exhibit a conspiracy of silence. They're not talking even about the issue, or they may adopt the confrontational type of approach. And the fourth stage, the most advanced one, is called using to feel normal. The person will continue to use despite any type of adverse outcomes. They will uh, continue to use as a loss of control and inability to stop. There is a compulsion in what they do. They use because that's their normal. They have to feel normal. They exhibit daily use with loss of control and paranoia, suicidal gesture, and self-hate, with really obvious physical deterioration in terms of poor eating and sleep habits. At this stage, the family may show frustration, anger, or even they may show signs of giving up. There are 4 elements, critical elements, that are needed for a normal human growth, and those are food, rest and activity, adequate secretions of hormones, and a satisfactory relationship with the caregiver. That person that will provide consistent and loving human contact and stimulation. Whenever one of those elements is insufficient or inexistent, the growth will be disturbed and the development will be delayed. Usually we observe failure to thrive in infants. Um, the infant will show a fail to gain weight and will show delayed development. And this is classified as failure to thrive. And we have 2 types of it. We have the organic failure to thrive when there is an obvious organic condition that contributes to that, that can be related to cardiovascular system, gastrointestinal system, or respiratory system. And we have what is called a non-organic failure to thrive, where no organic condition is established. However, those infants that are exhibiting non-organic failure to thrive will be listless, will have a very low weight and height, will have a poor muscle tone and loss of subcutaneous fat. Um, they may not move for very long periods of time, and they may seem unresponsive. Um, they will not respond to cuddling or to vocalization. And in all those children, um, we need to look into their mother-child relationship. We need to observe that because the non-organic failure to thrive is a complex condition that have both physical and psychosocial um, issues. Um, in the families of those children that show failure to thrive, there is a disrupted disrupted relationship. Um, there may not be a close relationship between the infant and the caregiver. Um, in some cases, the proper attachment has not occurred. That can be an environmental issue, such as a knowledge deficit of what to expect as a parent. There may be marriage issues, stress, or poverty. They may be psychosocial disorders such as depression, drug or alcohol abuse, or mental health issues of the caregiver. Often the father is absent or emotionally um, unavailable, and that will add to the mother's feelings of isolation and inadequacy, and that will lead to an added stress and conflict in the relationship between the mother and the baby. Children with non-organic failure to thrive often they may be seen as difficult or irritable babies because they're so listless and passive and do not seem to care about feelings. Um, they exhibit something that is very typical and is called the rumination. That's a voluntary regurgitation, um, probably as a mean of self-satisfaction when the desired response is not received from a caregiver. Um, Whenever the rumination will occur, there is a chain of events that will activate. Um, the child will lose weight, will become up to a point where will be severely emaciated with gross listless and irritable and smells sour because of this frequent vomiting. Um, None of those will make the baby attractive or anyone wanting to cuddle and show off. In terms of diagnosis, the child must be evaluated thoroughly in order to rule any systemic or congenital disorders. Signs of deprivations are important elements in the diagnosis. And once the child is exposed to a nurturing atmosphere and it becomes to improve, the state of the child starts to improve, that's what will settle the diagnosis. The treatment initially depends on a good nursing care, and we need to reinforce the teaching about childcare skills, and we need to act as a role model. We need to support the caregiver-child interaction, and all those will reverse the child's growth failure and begin an improved caregiver-child relationship. The process is difficult, most of the time uncertain, depends on the support and counseling of the family, and it's a very long-term process. Will require a multidisciplinary team that will include, besides the caregivers, the family therapist, the clergy, sometimes social workers, public health nurse, and the healthcare providers. We'll discuss now eating disorders, and we'll start with the first one that is called anorexia nervosa. Um, there is an increased preoccupation with reducing diets and a competition for being perfect, very thin. And all those elements will result in self-inflicted starvation. And this will be pretty much the definition of anorexia nervosa. Usually, well, it's most commonly seen in adolescent white females, however, have been reported among males and also among other races as African American, Hispanic, and Asians. Um, it's been known for more than 100 years, however, has an increased incidence in the recent years. And we think that will affect the incidence is up to 1% of the adolescent girls. Is very common in developed countries. And the onset may be seen as early as adolescence. Um, there is considered a psychiatric condition because of a severe psychological damage and the um, risk of death. In terms of characteristics, the children with anorexia are extremely successful students. They are perfectionists. They are trying to please everyone, the parents, the teachers, everyone. They will usually show very little emotion and will not display any evidence of conflict inside the family. They usually live in controlled family environments with parents that do not express emotion. Um, Depression is very common in this type of adolescence, um, and whenever they are asked about their anorexia, they will deny any weight loss and will actually perceive themselves as fat even when they look as a skeleton. They will be observed to adhere to a very rigid program of exercise in order to reduce their weight um, as much as possible. They may have all kind of rituals of cleanliness and order in their environment. They have rigid schedules for studying, very ritualistic behavior, will deny hunger, and will suffer sometimes from fatigue. In terms of diagnosis, well, patient with anorexia is visibly emaciated and in some cases may look almost like a skeleton. They look very young, sexually immature, with dry skin and brittle nails. They will start showing lanugo, that down hair over their back and extremities, which is a protective um, um, adaptation of the organism to very low temperature because they have those changes in metabolism. They have amenorrhea, constipation, hypothermia, bradycardia, low blood pressure, and anemia. They will eat very small amounts of food daily with an over-exercising, physically exercising themselves. And they have a BMI that is way below the normal BMI that they need to have for their age. In most cases, in terms of treatment, the anorexia children will be hospitalized in order to correct the malnutrition and also to identify and treat the psychological cause that is leading to the condition. Again, it is a multidisciplinary treatment. And there is an addition to that will be family therapy, nutritional therapy, behavior modification will be necessary. Keep in mind that the adolescents that have anorexia are very good in manipulating others in their environments. Um, Whenever the treatment is instituted, they may try to avoid gaining weight by ordering only low calorie foods, by throwing away their meals, by exercising in the hall or jogging extreme. Um, in some very extreme cases, there will be a need of a nasogastric tube feeding or TPN or total parental nutrition to provide nutritional support. Group therapy may be used to provide peer support and an opportunity to see and associate with others that have the same diagnosis. The long-term outlook for the child will be to stay anorexia clear, to do not have recurrence of the same behaviors or same patterns. Bulimia, or bulimia nervosa, is characterized by binge eating followed by purging. Typically, um, a child with bulimia is a white female in late adolescence. Um, Most of the cases, this person is at normal weight or slightly overweight. Um, those that are underweight will fill in the category of anorexia nervosa. However, some people with anorexia will also periodically practice this kind of binging and purging type of activity. The binging often occurs late in the day when the person is alone. There is done in secrecy, and that's an important aspect of the process. The individual will eat large quantities of food within 1 or 2 hours, and they will feel very guilty about that. They will start to feel fear or shame, and in order to avoid weight gain from the food eaten, will start binging. Will follow the binging will be followed by purging by means of self-induced vomiting, laxative, diuretics, or excessive exercise. In order to diagnose bulimia, there are some clues. There will be individuals with a lot of dental caries and erosion from the frequent exposure to stomach acid. They will have throat irritation. They may show endocrine and electrolyte imbalances that may lead to cardiac irregularities and menstrual problems. We may observe calluses or abrasion on the back of the hand from frequent contact with the teeth while inducing vomiting. They may show up with esophageal tears and acute gastric dilation. Hypokalemia is frequent in this type of patients because of the abuse of diuretics to prevent weight gain. A person with bulimia usually will consume a large amount of food in a short period of time, usually hours, and they have no ability to stop or control eating. The episodes of binging usually occur over a period of time, and those episodes are followed by some methods to prevent weight gain. And all those elements together will put together will give you the diagnosis. In terms of treatment, the treatment is multidisciplinary, and it's include a variety of treatment depending on the actual case. It needs to be applied to each of those cases. Uh, we may try and have the patient keep a food diary in terms of assessing the child's eating patterns. In some cases, medication can be used as antidepressants. Support groups are very helpful in those situations. To summarize the goals of the treatment, we'll need to minimize the possible complication of the condition along with making sure that all the uh, nutritional needs as well as psychological needs of the patients will be met, including improving body image, self-concept, and self-esteem. Obesity is seen now as a national problem in the United States in the general population, not just in the pediatric one, but also in the adult population. And is the result basically of the overabundance of food with not enough exercise. Obesity is defined as an excessive accumulation of fat that will increase the body weight by 20% or more over the ideal BMI, while an overweight patient, not necessarily obese, would be someone that has more than average for their height and body build, higher than the BMI that is expected for them to have. Whenever the obesity starts in childhood, it will lead to many complications in the adult life as a result of chronic obesity. Beside the fact that those children will feel isolated because they feel embarrassed and they are not participating in sports and they are not burning out all the excess calories, they may develop at a very young age diabetes mellitus type 2, which formerly was seen only in the adults and now it's seen in uh, more and more children as a resistance of the tissues to high levels of glucose. resistant to insulin because of the high level of glucose. Um, the obesities in children may start as a result of a vicious cycle that it's the the child use of food to satisfy emotional needs. Um, Something else that happens in those obese children is the fact that they are skipping meals, especially breakfast, while having a late night eating. And all the calories ingested late night will not gonna be burned because the child is going to sleep. And all that energy will be stored as fat. In other children, we may see what is called polyphagia or compulsive overeating. They have no control over their food intake. They cannot uh, postpone their urge to eat. They will even hide food for later secret consumption. Um, in this type of behavior, the child is eating when he's not hungry and is not actually doing it from an eating because of an emotional need. Um, However, not all compulsive eaters are overweight, and in some of those, the disorder may resemble anorexia. Development of obesity definitely has many factors, may include genetic and social and cultural, metabolic and psychological ones. Um, Children with obese parents are likely to share the same problems, not because it's some inherited predisposition towards obesity, but because there is a certain pattern in that family of related to eating and the emotional climate surrounding food. In terms of treatment, obesity is very hard to treat regardless of the age group, but it can be especially difficult during adolescence. Um, a lot of the teenage life will um, be centered on food, after school snack or ice cream shops or late night dinners or pizza parlors or fast food restaurants. All those have nutritional have high calories with little nutritional value. Diets that put an emphasis on nutritionally sound meals and reduce caloric intake may produce very slow results in teenagers especially. Um, that's why they become the market for weight loss programs and diet pills and diet books. The treatment needs to be multidisciplinary, and we need to explore the child attitude towards food. Um, there may need to be an association between a psychologist or psychiatrist, nutritionist, nurse, and other counselors. Um, the child may need to have a change in their schedule, that they will have a calorie controlled food, exercise, activity um, to um, keep the child busy and keep their mind away from the food. Tell whether the following statement is true or false. Obesity is especially difficult to treat in adolescence. Obesity is difficult to treat in any age group, however, especially difficult in adolescence.